First, I'd like to just thank Dr. Tran, Dr. Dukas, Dr. Bush. Magnificent talks. Those are really fantastic and very exciting. But now it's my privilege to introduce our keynote invited speaker, Dr. April Boyd. Dr. Boyd is a vascular surgeon scientist and professor of surgery at the University of Manitoba. Dr. Boyd graduated from Queen's University and completed a master's and PhD degree in physiology at the University of Toronto, where she also completed her MD, her general surgery, and her vascular surgery training. She's internationally known as a star in the world of vascular surgery, and she has served as the president of the Canadian Society for Vascular Surgery. She's an expert in the pathophysiology and hemodynamics of aneurysms and their development, and her research focuses on developing a better understanding of the factors that lead to aneurysm formation and growth, and ideally will one day actually tell us how to precisely predict aneurysm rupture. Her research was selected, as we saw from Dr. Dukas, was selected for the cover of the JVS-Vascular Science inaugural issue, and she currently serves on our editorial board. Dr. Boyd.
Wow, Alan, thank you for that amazing, I don't know if so true introduction, but thank you. Again, thank you, Alan, for inviting me. Thank you everyone from the JVS-VS for the invitation. It's my pleasure to talk about gaps and needs in AAA basic science research. I have no disclosures, and I think it's important to bring this out, but I do have a disclaimer, and the disclaimer is that I'm going to be presenting what I believe to be the next steps in research, basic science research of abdominal aortic aneurysms based on our work. I will touch on the work of others and what I think is coming along in the pipeline, but within 10 minutes, I can't cover it all. I just want to highlight the things that interest us the most. So as Dr. Dukas showed, we really got interested in looking at computational fluid dynamics and aneurysms after a VRIC meeting eons ago, I think in the early stages, where Ron Dahlman was speaking about understanding aortic tissue means understanding flow along with the tissue. And I remember coming back very excitedly to my husband and my research partner, who is an engineer and the head of mechanical engineering at the university where we currently are. And I said, do you think you could model flow in an aorta? And that was a big question, is what's an aorta? And we started there, and we've come so far, graduating students, and it's been quite enjoyable research. But what we set out to do was to see if we could correlate flow dynamics with what has been known as standard sort of static wall pressure, finite element analysis of local wall stress, not wall shear stress, and rupture location. And when we started, we thought, okay, we're going to do computational fluid dynamics, and we're going to show that our aortas rupture exactly where there's dominant flow impingement, and that'll correlate with the finite element wall stress data. And 3 patients in, we thought something really funny here. The red arrows indicate the location of dominant impingement, but the ruptures were not occurring in that location. And ruptures were also occurring where there was more interluminal thrombus, which kind of puzzled us. And then I began to read the work of Vorp, who stated that, where interluminal thrombus is deposited, there may be relative hypoxia, there may be a higher inflammatory signal, there may be something. And it was quite a surprising finding for us, and it has led us down a very interesting path. Now I'm going to get very clinical with everybody for a moment. This is a case of a most unfortunate 78-year-old gentleman. He had a 5-centimeter aneurysm, and he was being followed by a vascular surgeon in a tertiary center. His aneurysm about 6 months earlier was 5 centimeters, and he was scheduled to undergo a repeat ultrasound. And once he reached 5.5, he was going to be considered for repair. He presented to his local rural emergency department that happened to have a CT scanner, and they ran him through the scanner when he presented with abdominal pain. They couldn't see anything. His pain kind of settled with some narcotics, and he was sent home. He returned 4 days later, and a repeat CT scan was performed, which showed no interval change in the size of his aneurysm. The radiologist now reported a subtle sign in the interluminal thrombus, and the interluminal thrombus is shown by this dotted line that is running around the outside edge, showed a blush of contrast going into the thrombus, and you could also see sort of speculation of the contrast as well, traveling through what now know are canaliculi within the thrombus. They didn't report this, but you can see that it's actually starting on day 1, and this is day 4. And would have been a massive lawsuit in every other country in the world, probably Canada. The man was sent home again. He had a collapse 5 days after the 4-day point, so 9 days into the start of his symptoms. And he was taken to the hospital, same old hospital that now did a scan to rule out an aortic dissection. Anyway, he finally had surgery. He had an uneventful repair. He died 2 years later of heart failure, and he gave me permission to use his films posthumously for understanding aneurysm rupture. And I find it very interesting that we believe and we see that aneurysms tend to rupture through thrombus. An autopsy study showed that 80% of patients who present with rupture that did not undergo surgery and rupture was found at autopsy had ruptured through an area that was heavily layered with interluminal thrombus. And it made us believe we're on to something, because what are the chances of all the cases where I would have someone have 3 discrete time points, I'd happen to pick up an aneurysm that actually ruptures through the thrombus if they don't tend to rupture through thrombus. So that got us going in one direction. This is the same patient, and the interesting finding is we see calcification on the outer wall. Here's a renal cyst that sort of gives us the same level of landmark. There was a loss of calcification in the aorta even before it began to expand. There was a small bleb formation on the outer wall of the aneurysm, shown in the red circle. And one of the more remarkable things is with symptoms, the aneurysm didn't change size until rupture. And what bothers me about that is almost all ruptures I've taken care of in males are about 8 centimeters in size. Were they 8 centimeters in size the day before they ruptured is my concern. We may be operating on aneurysms that were smaller at the moment of rupture than they appear to be when we meet the person with rupture. Now, it's only one case, but it is a concerning finding. And again, we showed that rupture occurred in a zone of recirculation flow. So we're quite interested in interluminal thrombus, but its role is controversial. It's in almost every aneurysm. There's some early engineering work that shows that it might be reducing wall stress. And I can believe that, as in most physiologic systems, something initially provides some protection, but then it continues to be deposited. There continues to be remodeling, expansion, angulation, and you get more of it deposited. And then it may go from protective to something that is more detrimental and may cause outer wall ischemia. Active cellular structures and proteases, like interluminal thrombus isn't it has active cells in it. They don't show any signs of apoptosis. They're active macrophage populations living within thicker layers of interluminal thrombus. It varies based on the region, with very active cells in the more sort of blood-like layer, more neutrophils, etc., and less cellular content as you move outward in the thrombus. Aneurysms may lead to degeneration, interluminal thrombus may lead to degeneration in animal models. There's some evidence of that. And of course, as I said, hypoxia. As Dr. Dukas showed, MMP9 levels are elevated where there's high interluminal thrombus. And based on Dr. Dukas's work, we saw that there was quite an inflammatory infiltrate. So our student, Matt Levesque, who's our brand new PGY1 as of July 1st, who will be starting in vascular surgery direct entry program, looked at IL-8 as a marker of neutrophil involvement in the wall. And again, we saw that higher ILT had higher neutrophils. The interesting thing, and not shown here, is that macrophages were no different. We used MCP1 as a marker of macrophage infiltration and could find no difference in different regions of high and low interluminal thrombus. So there may be something quite exciting going on with neutrophils in particular, at least in relation to interluminal thrombus. So what are the gaps? Well, my point is, if only. I think almost any non-engineer could finish this bridge if they had to. They'd find some way to do it, but that's not what's happening in basic science, AAA research. We get a very exciting finding in a mouse, and we start building a very strong scaffold to do a human study. We don't really know where we're going, but we're getting some really nice, impressive structure built. And then many bridges end up looking like this. We go no further because we don't find the same thing happening in the human population. And we need to find ways to find where the bridge is going. And the more we do, the more we'll understand. And we need to bring in so many areas. So what do we need to do? This is an extremely busy slide, and I apologize for it, but it's my mind map of what's going on and where do we need to work. Now, I'm not going to be doing research on every one of these areas, but I think computational fluid dynamics is a really important part of understanding aneurysms, but you need to mesh that with the solid mechanics, and you also need to be able to look at fluid structure interaction. Most of the modeling we do is on rigid walls. We need to model, although we do model pulsatility in a receptive wall, particle deposition, that type of research needs to continue. I was most impressed by Dr. Tran's research today. That's the type of stuff we're talking about. If you have projection of fenestrated limbs into the lumen of an endograft, are you getting more thrombus deposition? Is that your response? Is that the reason why stents thrombose? That's interesting research and a good application. Geometry is another area of interest. There's a paper that we presented at the SVS, not by our group, but by another Canadian group, that believes that the more your aneurysm deforms, the less likely it is to rupture. It is an adaptive response. And then if you don't have as much deformation, you have higher risk of rupture. We've yet to look at this with our patients. Popliteal artery aneurysms, well, why look at that if we're talking about infrarenal aneurysms? Patients have similar genetic profiles, will have an aneurysm behind the knee. And in fact, if you have bilateral popliteal aneurysms, you have a high risk of having an infrarenal aneurysm. But their behavior is different. Their MMP9 level is slightly different. Their MMP2 level is very different. So they seem to be forming in the same person, but one tends to rupture and one tends to embolize. In understanding the differences between these two types of aneurysms, you get insight into what's going on in infrarenal aneurysms specifically. We intend to continue looking at interluminal thrombus, and I'm happy to see Dr. Bush's work. I'm really in need of an animal model of something that is other than death, because most of the aneurysm models we have in mice is an aggressive chemical injury to the wall that, if untreated in these mice, will result in rupture in almost every case. So we need a larger animal with more stable aneurysm formation over time to get a better sense of what's going on. It just depends on how we're going to induce that. And I'm leaving that to other experts. The same with genetics. Genetics won't be, does your loved one have an autosomal dominant, Marfan's-like transmission? It'll be way more specific into the mechanisms of collagen and elastin failure in patients' aneurysms. Risk factor modification, we all know that aneurysm incidence is going down, and I do believe it's a direct reflection of a decrease in smoking. However, pot is legal in Canada from coast to coast, and we are seeing a significant increase in smoking. It doesn't matter what you smoke, it's the fact that it's on fire and the products of combustion are associated with aneurysm formation. I think we'll never be out of business. Medical treatment is important, but to date, not one single drug that we have tried has halted the progression of an aneurysm's growth. But if we don't understand the core biology of the wall, we will never come up with a proper medical treatment. Sex differences, I think it's important because just like popliteal aneurysms, where there are differences, there is understanding. And I think because aneurysms in men and women behave slightly differently, that, especially in looking at tissues, that's where we may get some answers and be able to target and prevent aneurysm expansion. Tissue analysis is important. We're going to continue with that, looking at differences in factors related to neutrophil infiltration. Can we block things in animal models? Will that halt the progression of an aneurysm? And then finally, endovascular repair. If you do an open repair, the aneurysm is treated. Unless you sewed too far from the renals, you're fine. The patient may get a hernia in the future, but you're not going to be concerned about their aneurysm or any suprarenal type of aneurysm forming. But when you put an endograft in someone 8 years down the road, there's remodeling, and it's not the type 2 endoleaks that are getting you, it's 1A and 1B. There's remodeling, there's change. What is the effect of radial force on an aneurysm neck over time? In a process that is inflammatory. Even though there's no aneurysm at the neck, you seem to induce one over time. And that's also an area that we're quite interested in. Thank you.
Thank you very much, Dr. Boyd. That was really fantastic. We could talk for an hour about it, but given the time, I'm just going to ask you two quick questions. Number one, I'm sure everybody on this webinar wants to know what you think of the doxycycline trials, and that's still a gap, and why didn't it work? Did we translate it wrong? What happened?
I think it's just the animal isn't, although we are all animals, we all came from the original plant or the original cell. There's something different in animal models. And the things that we find, the aneurysm is just too simple in the model. It doesn't take into consideration all the factors. And I cannot answer why it isn't working in humans. I'm excited about the possibility of metformin as having diabetes is a negative risk factor for the development of an aneurysm. Could we stabilize the growth of aneurysms using metformin? I don't know, but that's something coming on the horizon. So far, it's very sad. I'm from the days of propranolol, when the K. Wayne Johnson and the big propranolol trial was out. And I remember being quite junior and thinking, this is going to be amazing. There'll be no more aneurysms. I really bought into it. And then, of course, it didn't go anywhere.
Thank you. And let me just ask one final question. I know this question's in the chat, but one final question. You told us all about the thrombus, and you really convinced me. That's fantastic. And I agree. David Vorp did some seminal work in this, continues to do work in it. It's done great work in Pittsburgh. But you did the work on CFD and made that relationship. How does intraluminal thrombus get started? And can you predict that with CFD?
Yes, you can. So we have, I believe that the deformation happens first. So it's a chicken and egg thing. I believe that there's a change in elastin and collagen that causes deformation. Deformation, just like when a river widens or when you have an abnormal angulation, there'll be a widening of the river stream, a zone of recirculation, and a dominant flow stream through it. So we have seen in aneurysms that we followed over time that for the most part, they tend to continue to deposit their thrombus in the same location. But if there's an angulation change in the neck, it's almost like a fire hose being pointed in a slightly different direction. And we've seen the other side of the aneurysm fill up with a change in neck angulation. So it's dynamic. And we've also seen that thrombus in rare circumstances goes away. And that is an interesting thing. So if it's so important, where did it go? And how is it not embolized? And did it go away, so subclinically that it didn't become an issue? So it's a little more active than we realized. And
maybe a little similar to Alex Kluge's concept of plaque regression. It can happen in the vascular system.
Maybe.
Oh, well, thank you very much, Dr. Boyd. And I want to thank again all the speakers very much. I want to thank all the participants, everybody who asked questions. This was really wonderful. And I'll just ask Dr. Glavitsky, our editor-in-chief, to close the webinar.
This was a great webinar, and I really wanted to ask April what's currently the best predictor of rupture, because I think we shouldn't go away from here, April, unless you tell us what is the best predictor currently of rupture.
Well, we know from animal models that saccular aneurysms have more interluminal thrombus, more disturbed flow, and we know when we see them, we operate on them. That's sort of the rule because they're higher risk to rupture. I still have to go with size because so much of the data has been about size, and I'm going to continue to use size. But I tell you, when I see a crescent sign in an aneurysm, when there's a little bit of contrast leaking into the interluminal thrombus, radiologists used to tell vascular surgeons, oh, that's a concerning sign. And most of us went, yeah, sure, didn't pay much attention, but now I actually do. I do pay attention to that crescent sign.
Wow, that's wonderful. I think it was really a great hour. We have heard and seen some beautifully illustrated great presentations at this international summit, and Dr. Boyd gave a wonderful lecture. Thank you very much. I would like to call your attention that there is a JVS webinar on Wednesday, June 9th. So all of you who came and listened to this should come to our next webinar on June 9th, Wednesday. Thank you very much for coming.